Medical Dialogues. I am Dr. Nandita Mohan, and today I have a very interesting topic for discussion in front of all of you. I will be talking to you all about analyzing the minimally invasive nature of transcatheter aortic valve implantation procedure, which is commonly known to many as TAVI or rather even TAVR. So, to give us a little detail into the procedure, its indications and benefits, challenges, as well as its various limitations, even the recovery phase to talk about it, we have with us an esteemed panel of cardiologists who have joined us today. We have Colonel Dr. MONIK MEHTA, who is a heart specialist in Gurgaon with over 25 years of experience. He has served in the Indian Armed Forces. He has thereafter also worked with various corporate hospitals and has vast experience in managing all types of heart problems and even doing complex procedures. He is a fellow and member of many prestigious international and national organizations, such as the Fellow of American College of Cardiology, the Fellow of Society for Cardiovascular Angiography and Interventions, International Fellow of the European Society of Cardiology, to name a few. Next, we have Professor Dr. Ajit Pillai, who is an acclaimed interventional cardiologist in the nation with extensive training and experience in the complex coronary, structural, and even endovascular procedures. He is well known for his brilliant procedural skills and high-risk interventional procedures, and he is trained in interventional cardiology in multiple internationally reputed centers. And lastly, we have Dr. Maulik Parekh, who is the head of TAVR and Structural Head Program. He is a proctor for TAVR procedure and has been actively teaching and propagating this new state-of-the-art technique to various centers across the country. He is also trained and certified for other structural heart interventions. He is a founder member of the Indian Academy of Echocardiography and is well trained in basic as well as advanced echocardiography. Welcome everybody to Medical Dialogues. It'll be a pleasure to be interacting with all of you today.
Thank you. Thank you. Thank you very much for the kind introduction.
So, Dr. Ajit, if I just may direct the first question to you, if you could just briefly explain what is TAVI and why is it considered a minimally invasive procedure?
Thank you, Nanda. So TAVI is a very common name now. It's as expands as transcatheter aortic valve implantation. Aortic stenosis. Aortic valve is one of the valve which directs blood from the left ventricle, which is actually the main pumping chamber of the heart, to the entire body. So with age, calcium deposits accumulate in this valve, and this valve undergoes stenosis or narrowing, thereby limiting the blood flow to the body from the heart. So that's called as aortic stenosis. And TAVI is a procedure where we replace this valve with a minimally invasive, which is actually the topic of discussion today. That means without opening the chest, we'll replace this valve through a small incision in the groin or the leg. So this is what is known as TAVI, that is transcatheter aortic valve implantation. It is also known as TAVR, which is transcatheter aortic valve replacement. Both are the same. This is essentially replacing your deceased aortic valve with a new bioprosthetic valve through a very minimally invasive procedure without opening the chest.
Great. Great. That was a very small, I guess, crisp introduction about it. So, Dr. Monik, if I may ask, if you're talking about TAVI, its detail and how minimally invasive it is, if I talk about the procedure as well as the recovery time, and how would you say will be the recovery time and patient experience when we compare TAVI with the normal traditional procedure?
So, with the introduction of new and exciting development that is TAVR, it's revolutionized the treatment options for patients, especially patients with aortic stenosis. Now, in earlier times, the outlook was limited. They had only one option, that was surgical option. But now, with this come about in the past, you can say in the past decade, this new modality. Now, this is a less invasive, or you can say minimally invasive procedure. So the advantages are that the patient's stay in hospital is very short. The procedure time is relatively shorter. The discomfort during the procedure, though the surgical procedure was done under general anesthesia, this is done modified anesthesia or maybe in general anesthesia or even in anesthesia. But the incision, there is no incision. there is that's why we call it less invasive, because there is max to max there is a stitch in the groin only. So it's less invasive. There's no incisions. There's no requirement of any complex equipment like a heart lung machine. So these are the advantages during the procedure. For the patient point of view, the recovery time is drastically, it's a different ball game. So for an open heart surgery, when a patient would be admitted in hospital and would stay in hospital for a longer duration, and the recovery would be longer. Now we are talking about days and weeks for a traditional surgical procedure. But in a TAVR, the recovery time is, we talk about in days. So you have at times we have a person who gets admitted on the day one, and we have on day two also we have discharged patients. So we are talking about days to hours. So 24 to 48 hours is what we traditionally see for a recovery from a for a TAVR procedure. And once the person goes home, the symptom recovery also, the person comes is feeling near normal within a week's time. So that's why we say it's a faster recovery time for the person, and that's why it's revolutionized the whole treatment modality and the options for patients with aortic stenosis in present times.
Great, great. So, Dr. Maulik, now talking about TAVI, the procedure, what, according to you, will be the primary advantages of TAVI over the traditional open heart surgical procedures?
So I think what has been discussed already. Apart from that, what I would believe is TAVI is a groundbreaking procedure. It was, and it's opened doors to many other such non-invasive procedures, and it is still a rapidly evolving field, and lots of new types of valves are available and being developed as we speak. So in terms of going from from invasive to minimally invasive, like from open abdominal surgeries to going to the laparoscopic surgeries, similarly here, going from open heart to the minimally invasive route, it is done under local anesthesia. Patient is awake during the procedure. Typical in a high volume center, typical procedure time is 45 minutes to 1 hour. Patient goes home the same day or sometimes the next day, and patient can walk the same day, and patient goes home without a single stitch in the body. Comparing to an open heart procedure where the average length of hospitalization is 7 days, recovery from the sternal or the open heart wound is typically 3 to 4 weeks, and risk of bleeding, infection, risk of ventilator associated complications, all these are much, almost non-existent with a TAVI compared to an open heart surgical aortic valve replacement.
Great. Now that we've talked about the advantages, the recovery time, as well as the patient experience and what actually the procedure is, Dr. Ajit, if you can just discuss or further add on to the potential benefits of TAVI for elderly patients or those who have been deemed at high risk for surgery.
Yes, Nandita. So as Dr. Maulik was detailedly explaining, this procedure is done in a very minimalistic way. So most of the time it's done through the groin, and the incision is around less than a centimeter, mostly about 5 to 6 millimeter to be precise. So that you can imagine is how small the incision is. So that's why the recovery is also going to be much faster. So as it becomes very minimally invasive, people think that it is very simple, and that's the way to go. It's not like that. That because we make it so simple, it means that it goes a lot of pre-procedure workup. So to fit in a valve which is as big as 3 or 2.5 centimeter through a very small millimeter incision means we need to image the heart, image the valve very precisely. So most of the workup happens pre-procedure or kind of valve implant. We would say that 90% of the procedure is done before the procedure. That means in the planning, and 10% is actually in the execution. So the TAVR experts are very good in planning which cases to select for a TAVI procedure and which cases to go for a surgical procedure. And once the patient is kind of eligible for a TAVI, then it is meticulously imaged the valve, the path in which the valve is introduced, starting from the groin to the abdomen to the chest. So everywhere is meticulously imaged with a CT scan and a lot of criteria. It's beyond the scope of this webinar to address all those criteria, but then we need to, there will be a team of doctors. It's not one doctor besides, we call it as heart team, which includes radiology, include cardiovascular, which is an interventional cardiologist, a cardiac surgeon, a cardiac anesthetist. So minimum of 3 or 4 doctors sit together and decide what is the way which is best for the patient, and then this TAVI procedure is planned. So once we screen and the patient is being selected, then as Dr. Mailuk was telling, that it is very easy workflow. The patient comes in, or during COVID times, we were even doing a daycare procedure. That patient comes in the morning, we do the procedure, the patient goes back in the same day to avoid hospital stay. So that's how simple the procedure can be. And all the advantages of avoiding an open heart procedure, avoiding a scar, everything we already discussed. But the most of the kind of workup is actually in pre-procedure planning. And of course, the doctor's skill set, the patient's general condition also matters with regard to the recovery. Majority of them are kind of discharged. I would say more than 95% of the patients are actually discharged on the same day. That is about 24 hours after the procedure.
Great. Great. So now coming to its technique as well as its application aspect of it, Dr. Ajit, again, if I may address it, or even Dr. Monik, if you can just help us understand how critical is the size as well as the nature of the incision that you just mentioned, that it's a very small incision since it doesn't require much of scarring. Also, it doesn't have much of scarring. It's a very small incision. Again, leading to what are the factors that can actually lead to a quicker recovery?
So one is the size of the vessel. As I mentioned, it is through the groin vessel. So through the CT scan, we'll get an understanding how big is the vessel which is actually going to take this valve delivery system. So this is already pre-planned, and roughly we say 5 millimeter. So anything less than 5 millimeter, it is a difficult task. Most of the patients do have a diameter which is 5 millimeter or above. So with the new generation valves, the profile of the valve delivery systems have come down significantly. So even in a smaller caliber vessel, we are able to now take this valve as opposed to the first generation valves. So this incision is basically can be made with ultrasound guidance. We use an ultrasound guidance to take this incision down into the vessel, and everything is planned. So we have CT aid, we have ultrasound guidance, everything. And the team is well prepared in an experience center. The team is well prepared to take this incision. As I mentioned, the smaller the incision, more planning is required. And after the procedure, it takes about 20-25 minutes for skin to skin, generally in a regular case. And after that, the skin incision is closed with a subcutaneous suture that also is absorbable. So once that happens, then I think the patient, usually the procedure is done under conscious sedation. That means patient is usually semi-awake, and so the patient is reeled back into the ward, and then after 4 hours, patient is made to walk around. And so that's how simple the procedure is. Coming to the criticality of the incision, it is by imaging. There are patients in whom the vessel will be very much calcified, where even taking a 4.5 millimeter the valve system is difficult. There we do some bed preparation, some peripheral angioplasty procedures to take this valve. But we have come a full circle as far as TAVR is concerned. Now with the team, every team is prepared to meet all the eventualities. What if the valve doesn't go? I told about the groin. So there are some cases we need to take through the neck. There are some cases we'll take through the arm. So there are various ways in which this difficult anatomies are also dealt with. Monik, please, you can add on.
Yeah. So in fact, we just covered the whole thing, and what we can say is in totality is that 99.9% of the time this procedure is closed on the table, and there is no requirement for even a suture. There are devices like the Angiography and the probe and the Percutaneous, by which we are able to close it's not even an incision. I think the better would be maybe it's just a puncture in the femoral artery. So these are so that is closed with these devices, and an incision or a suture is a very, very, very rare occasion in case, especially as if there's calcification of the artery very small, or there has been some issue while traversing the valve and there's been a tear. So, though our surgical colleagues are always on board, as mentioned earlier, this is a combined procedure in which the standby cardiac surgical colleagues are always available. So just for that rare eventuality, in case some issue happens, it can be closed surgically. But that is practically unheard of nowadays, and it's just a theoretical possible probability. So the closure is done on the table, and the person will not even notice that there is any suture or any cut on the leg once he or she recovers in the post-operative room or the recovery ward.
That is very great. So I guess drawing out the advantages of this is higher. So again, Dr. Monik, if I again further, as well as Dr. Maulik, if you can just tell, if I talk about how cardiologists can actually determine which patients are suitable for TAVI, now that we're discussing about those who are non-surgically involved, or the high-risk patients who are who can be indicated for undergoing surgery and for TAVR. So if you can just briefly explain to us what are the main characteristics that the patients might have for they to be eligible for undergoing TAVI procedure.
So I'll take the question first. So how we go about it is initially first we go out to call a case selection, and there are some basic rules or some basic guidelines. So all of physicians and everybody is aware that for aortic stenosis, once a person is symptomatic or it is severe aortic stenosis, then the age is a very important criteria to decide which direction they would go. And we have got this information is backed with data, and the data is what we call as randomized controlled trials. So this is actually the gold standard for evaluating the significance and the outcomes of any treatment. So we have got now randomized controlled trials for TAVI in various age groups. So these age groups and in various risk profiles. So grossly we have younger people, middle age, and elderly people. And then we also have a categorization of low risk, moderate risk, and high risk. So this is the initial clinical approach that any doctor should have before thinking about which procedure one should go for. So if you are talking about the age profile, now the younger patients, the younger population, that especially we can take, say the age is of 65 years, that would be a cutoff period. So anybody less than 65 years, we are still suggesting that they should go in for a surgical procedure, because the 2 pointers for that are the outcome for the TAVR valves, which are basically tissue valves. The longevity and the durability of the TAVR valves for a longer duration, for a person who's younger, who's got another about 40-50 years life ahead of him, the durability of the tissue valves, that is the TAVR valve, is still has to be proved in randomized controlled trials. So anybody who's less than 65, surgical option would be the first choice. And another reason is that younger people, the chances of having complex anatomy in the aortic valves, that is like for example a bicuspid aortic valve, would be more in younger people, and TAVR is traditionally suited for a tricuspid aortic valve stenosis. So coming back to the main moot point is that anybody less than 65, we should still offer them first choice is the surgical option. Then the other extreme is anybody around 80 years and above. Because we are looking at the two modalities, that is TAVR and surgical option, that is the SAVR, that is the short form. Now both have got equally good outcomes, and there are now randomized controlled trials which say that the TAVR is equally good as compared to SAVR in the ages of around 50 years, in 80 years, and in high risk patients. So that is why in anybody in 80 and above, why we should give them both the options. And now TAVR is a minimally invasive procedure. Anything which is minimally invasive should be the better option that should be suggested. So 80 and above, we should look at both the options, and TAVR being minimally invasive would be the preferred option. Now we come to the middle group, that is the group between 65 and 80. Here both options are available, and again depending on the minimally invasive option, obviously the TAVR is would take the
Primary
preference.
option.
And here again we have randomized controlled trials which show that TAVR is equally good, and we've got data for up to 5 years. So, so anybody in the older extremes of age, TAVR would be the preferred option. Now we talk about the risk profile. Now the risk profile is gauged not only by age but by other comorbidities, what we call as frailty index, how frail the person is. Has the person got other diseases? Then what we call as the lifespan of the person. If the lifespan is limited, but we want to give quality of life, so all those issues are there. So the more frail the person, TAVR would be the better option. The more younger the patient and who is a low risk, surgical is the better option. So that's how the initial starting point for clinical evaluation of the person should be. This is at the level of the general physicians, who are the persons who are at the first in contact with patients with aortic stenosis. Thereafter, then there is a further detailed evaluation about suitability for TAVR that we can go on.
Dr. Maulik, do you want to add on any pointers to this?
Yeah, so just to add to what Dr. MONIK said, there is now 10 years data available for TAVR valves, 10 years randomized control data compared to surgery, durability data. That is one point. Second is more than age group, we look at the risk for open heart surgery in a given individual. A patient may be 50-year-old, but a very high risk for open heart surgery, and a patient may be 75-year-old or 80-year-old, but low risk for open heart surgery. So this is one point, that looking at not the age but the risk of the open heart surgery. Now, low risk for surgery, intermediate risk for surgery, and high risk for surgery. All the three groups are now eligible to get a TAVI done. Now let's say patient is low risk. So for intermediate and high risk, definitely TAVI.
Yes.
Now let's say patient is low risk. So in low risk, you go to age.
All
now,
right.
age-wise, anybody who's between 50 and 55, it's a gray zone. Person who's less than 50 typically is a candidate for a metallic valve, not a tissue valve.
Okay.
So definitely open heart surgery. Above 55, between 50 and 65, maybe an open heart surgery with a tissue valve or a metallic valve based on patient's profile. And above 65, you can safely offer TAVI to every individual, whether it is low risk, intermediate risk, high risk. You can offer a TAVI, what I'm saying. Then you can evaluate the patient for TAVI, do a CT scan. If CT scan tells you that this patient is a very, very suitable candidate for a TAVI, then patient is, let's say, 65-year-old. And CT scan tells you it's a very good anatomy for TAVI, then you go ahead and do that. But if 65-year-old patient who's low risk for open heart surgery, and when you do a CT scan and you see that, okay, the leg vessels are smaller, or the valve has calcification at abnormal places where it is not suitable for a TAVI, or becomes high risk in case of TAVI, then you exclude TAVI option and send the patient to surgery.
So in all these, I will just like to cumulatively add, so it is the case selection. You cannot just randomly categorize as age-wise distribution. It has actually to be case, because each case is going to be different. So case selection is priority, is important in determining whether we conclude and coming to a TAVI procedure, whether they are indicated for a TAVI or not. Correct. Yes, agreed. So now talking about its, so talking about its challenges as well as its limitations. So Dr. Maulik, again, what are the current limitations or challenges that have been associated according to your experience in TAVI procedure?
So as we discussed, any tissue valve is likely, whether you do open heart surgery or you do a TAVI. In both, you are putting tissue valve. Tissue valve has a finite lifespan. It is going to become again narrow in maybe another 10 to 15 years or 17 years, depending on patient's body's interaction with the valve tissues. So TAVR valves, like the surgical valves, the tissue valves. So the limitation is that there is going to be degeneration after 10 to 15 years, and patient will need another procedure, maybe a TAVI in a TAVI or a TAVI in a surgical valve. That is one limitation. Second limitation is current, although to overcome this limitation, there are some non-tissue TAVR valves are in research and development, which are going to be polymer-based valve. The leaflets are going to be polymer, and which are likely to last much longer than a tissue valve. That is one part. Second challenge is with TAVI. Currently, the risk of pacemaker is slightly higher compared to the open heart surgery. So somebody whose ECG is already abnormal, or somebody who already has a RBBP or a first degree AV block, you are even more likely to get a pacemaker after a TAVI. So that is a challenge in TAVI, that the risk of pacemaker is higher than open heart surgery. And the third is, sometimes if you don't select the case and the valve properly, I mean, there are various types of valves available, and depending on the CT scan, you can decide which valve to use in which patient. So sometimes if you don't select the case or the valve properly, you may end up having a paravalvular leak, AR, or aortic regurgitation, from the sides of the TAVR valve. So that remains a limitation. So these are the, I think, limitations as far as the TAVI is concerned. There are a couple of complex things that are there, like coronary alignment and all those things, but I don't think those are the topic for discussion in this current audience. And but these are the major limitations as far as what I see.
I'd like to also at this stage add that there are certain limitations for surgical aortic valve replacement. So you've been talking about limitations for the TAVR, but we should also tell patients what are the issues with surgical aortic valve replacement. So besides the length of stay and the incision and the recovery time, the other issues are that there is more chances of aortic atrial fibrillation with surgical aortic valve replacement. Then there is a relative or more finite chance of having a acute renal injury with surgical procedure. So this is when we are comparing the two. So it's our job to tell the patient that with a TAVI you might have chances of a pacemaker, you might have chances of a leakage around the valve, but with surgical you might have chances of atrial fibrillation, you might have a renal problem, or you might have bleeding issues. So these are the medical issues which should also be informed to the patient, especially the middle zone patients who are eligible for both the possibilities, both the treatment options.
Great. So, Dr. Ajit, are there any new research findings or clinical trials that you are aware or that you find particularly promising in the field of TAVI?
Namita, the TAVI, as we were discussing over the past half an hour, is that it has become a standard of care as far as aortic stenosis in elderly patients are concerned. With growing experience, the indication have become expanded. One is actually the patient-related factors. Like now we are looking into low-risk TAVR, as it already mentioned. That means somebody who is at low risk of surgical valve can also be a potential candidates for TAVR. The durability concerns have been addressed. We have now new dry seal technology. We have now new technologies where the valve degeneration is being prevented. This is taking a leaf out of from the bioprosthetic surgical valves. So one is actually the valve design. Second is actually, as mentioned, patients who have not severe aortic stenosis, but patients who have moderate aortic stenosis, because as you know, this is a disease which is going to progress. So before the valve stenosis affects the heart in a very substantial way, we treat moderate aortic stenosis with surgical or even percutaneous therapy. So that is another area where the research is going on, and so far the findings have been very encouraging. The third thing is actually asymptomatic aortic stenosis. Now we have clear-cut data. We're saying that even with patients who are not having any symptoms, incidentally picked up to have significant aortic stenosis, they do really benefit with aortic valve replacement transcatheter. The fourth thing is actually with regard to the valve delivery system. I already mentioned that we now currently have the second generation valve delivery system, which have come down significantly in the thickness of the profile. And now engineers and R&D people are actually working on delivery systems which are as small as 9 French, which is like less than 3 millimeter. So that will be really a path-breaking thing where we really do not even consider an incision. Actually, it is just like a regular procedure where patient walks in and goes off. So we really, that will minimize the vascular concerns we were having. So valve delivery system, valve design, valve frame design, patient profile. So all those some of the very interesting ways actually we are actually discussing. The another thing is actually TAVR in TAVR or TAVI in TAVI. Somebody, as Dr. Maulik was mentioning, we stretch the durability concerns to 10 years or 15 years. What if the valve stenosis early, let's say 5 years or 7 years down the line? So what will you do? Patient will continue to be still high surgical risk. So now we have research findings which is encouraging to put a valve in valve, especially a TAVR in TAVR. We are already doing TAVR in surgical valves, but now we have data for TAVR in TAVR. So we need to have some design concerns. We need to know how we implant the valve and how to de-valve or kind of leaflet modification or de-valve leaflet. So all these things which are going on. So a lot of research is going on in this area. We have newer valves coming in. Not only from the West, but also from our country after the Make in India campaign. So a lot of things look up. There's a very entertaining and very encouraging field. Someone who's working in the structural heart. The next 10 years is going to be a kind of a revolution as far as structural heart disease intervention is concerned. So lots and lots of research, lots and lots of bench testing, and lots of studies are going on in this field.
Great. So definitely it will be a message coming out of you, all of you, for the next 10 years for the budding cardiologists in the field of TAVI. So lastly, if you could all just briefly advise, what advice would you all be giving to emerging cardiologists who actually wish to specialize in TAVI? Dr. Monik, if you can just give us your piece of advice.
So I would advise all my younger colleagues to approach this field with open arms. This is going to be the default procedure, the way things are going, and they should get their hands on to this new technology and the medical procedure. Though there are some procedures in which there is a lot of enthusiasm. This is one procedure which requires enthusiasm, but more than that, it requires planning, case selection and planning. So one has to be very meticulous. And during the initial exuberance of doing a procedure, one should not forget the planning. In fact, it is said that this procedure is 80 to 90% planning and pre-planning and case selection, and the procedure itself is only 10 to 20% of the hard work. So they should go through that part. There are a lot of treatment options, training options which are available nowadays for the younger colleagues. So there are fellowships, there are proctorships, there are webinars, so there is a lot of information available for the younger colleagues. So they should be totally well versed with with the procedural part of the procedure. They should also be aware about the complications, and that they will be aware if they are aware about the procedural issues. So what are the possibilities? This procedure, the procedure can be only 45 minutes to an hour procedure time, but in case there is an issue, that is a big challenge. So the bottom line always should be that whenever we are doing a procedure, we have to ensure that we are covered up for all the complications. So 99% complications will not happen, but the preparation for all the complications should be there, and that preparation includes starts off with your education, your approach with the various technicalities, the methodologies. One should be aware and familiar with the hardware, what valves you are using. One has to be familiar with that, and lastly, one has to be familiar with the patient. It's a combined approach. So one should not neglect your initial physician, your initial the treating cardiologist who's been following up this patient for past 20, 30 years. And then a lot of time it happens that once a patient is referred to us for a TAVI, the initial doctors, the physicians who have been caring for the patient for so many years, they lose touch with this patient. But since they have been following the patient up, they know all the sensibilities and all the issues regarding the patient. So it's very important that we include that the primary the physician in the heart team, because that's how we will end up with a good result and a satisfied patient.
Dr. Ajit, in the meantime, if you could give us your piece of advice.
I think my advice would be, as I mentioned, this is going to be a revolution in the interventional cardiology. It's already a revolution and keeps improvising. The TAVI lab landscape is going to be expanding. The one point I would like to add, in addition to what MONIK said, is actually always stick to basics. That's very important. As I mentioned, 90% is actually in the planning. So one should know the basics of imaging. That's very important. Understanding cardiac CT is very important. The procedure is, as mentioned, it's nothing. It's just 10% of what you plan. So procedure planning will include kind of understanding the anatomy, and how you are going to do the procedure is secondary. Second thing is actually it's always better, because it's not like coronary procedures. The number of procedures are definitely going to be smaller. So try to get associated with as much with the senior cardiologists who are doing the procedure, and that will improve your understanding of the procedure skills. In few years' time, there are a lot of valve designs you will be doing with. Each one, unlike coronary stents or something, each one is different. Each valve has a definite its own way of deploying, and procedure skills are different. So that makes it difficult, at the same time very interesting as well. So I think sticking to basics is important. Understanding the imaging, understanding your hardware, and understanding the valve, whichever valve we are actually going to be doing it. These are some of the things I would like to add on to what MONIK already told.
Now coming, Dr. Maulik, your piece of advice.
So I think just everything has been said, and what I want to say is a lot of material is available online on YouTube. On a lot of live cases are available. Lot of data is available online. So learn from those things, attend conferences, and gradually get into the groove. And as Ajit very rightly said, understand the procedure well, understand the imaging part of the procedure, and ultimately, I mean, it's not a very complex procedure to do.
Great. So thank you so much, Dr. Ajit, Dr. MONIK, and Dr. Maulik, for joining us today and giving us all your valuable insights. We've covered a very interesting topic, and I guess in the next 10 years, it's definitely going to be a revolutionary change in the field of cardiology. And thank you so much for all your valuable insights and joining us at Medical Dialogues today.
Thank you.
Thank you.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.